Welcome to Everything Health, produced by the A. Philip Randolph Institute. Tonight's segment is sponsored by Kaiser Permanente, one of labor's premier healthcare providers. This is the first of many conversations about health and healthcare in America. Tonight's inaugural segment will be hosted by Cleola Brown, president of the A. Philip Randolph Institute. So sit back and enjoy as we explore everything health together. And at any time during the show, you can post a question by using the Q&A feature located at the bottom of the Zoom application. And your question may be featured during the Q&A segment later in the program. Once again, thank you for joining us this evening as we start the show.
Good evening. Good evening, everyone. And I am excited because I'm looking at Dr. Kim Sydnor on the screen. First, let me take care of the housekeeping pieces that I want to do, that I have to do, or they scream at me. But I want to get to Dr. Sydnor so bad I'm grinning like a Cheshire cat. I see some familiar faces here on the side screen. Thank you. Welcome back. For those who are joining us for the very first time, you're in for a treat. We've got one of our best guests ever with us this evening. As I said before, our guest tonight is Dr. Kim Sydnor. She is the Dean of the School of Community Health and Policy at Morgan State University. And she is the director of the newly established Center for Urban Health Equity. She also serves on 2 state committees, Minority Health and Health Disparities Advisory Committee, where she's the vice chair, and the Racial Disparities Opioid Task Force. This is a sister who spends her time doing all of it. Dr. Sydnor has collaborated with APRI on several projects over the years and is one of our longtime friends. We are absolutely delighted to be with her as our guest tonight. And please join me in welcoming Dr. Kim Sydnor.
Thank you, President Brown. You know, this is always a mutual admiration society thing going on here. Because, truly, you are the hardest working woman anywhere that I've ever met. You do all things and do all things well. APR, I'm so happy to be affiliated with the organization. It does such groundbreaking and necessary work in the space of equity for all workers. And so I know you all are proud of what you're doing, and I'm happy to be affiliated and associated and really excited to be here tonight. You know, I really don't like doing the PowerPoint presentations because what we like to do is talk and chit chat and engage intellectually. So I'm going to do what's appropriate and academic, but I hope we have a chance to really just have a good conversation in this particular space about what's going on.
Well, absolutely. Thank you, Dr. Sydnor. The floor is yours.
To that end, I think I get to share a screen now. Let me again introduce myself, Kim Sydnor. I'm the Dean of the School of Community Health and Policy at Morgan State University. And for those who are not familiar with Morgan State, it is a historically Black university in Baltimore, Maryland. We are a research institution. We have connections, I'm proud to say, with stakeholders across the country, across the globe, and we are heavily invested in the future well-being of particularly communities. That's part of our mission and vision, is to make sure we do that work. Tonight, I'm coming to you with an opportunity to talk about one of, unfortunately, necessary topics, which is health inequity, to really get to its root cause and implications and what that means for folks who are on the line in terms of every day. So I bring you, I hope, the academic side of it, but more importantly, what does that mean and what utility does that have in the work that you do in your everyday lives? But of course, some of you do a lot more work than I do, so I'm not assuming or presuming anything, but I hope this work is relevant for you. So you've heard this term, I hope we've heard by now this term, the social determinants of health. It's been broadcast in the midst of COVID. Public health has now become a term that's no longer affiliated with just the clinic on the corner, that people have begun to understand that public health is large, significant, and influences every part of our life. But part of that work is understanding that health is determined by more than just what happens in a medical office, and even more than your genetics. And I know that's kind of hard for folks to grasp sometimes, but we need to think of health broadly. So social determinant says that where we live, where we learn, where we work, and where we play or recreate really have an influence on our health and well-being across a variety of health outcomes and quality of life. So I know folks will say, well, I thought it's my individual behavior. You're telling me to eat right, do all these things right. That's yes. This is a yes and. So I want to make sure the message isn't out there that this is a either or. This is yes and. And so the picture you have on the screen, isn't it idyllic and cartoonish? It's lovely. We got green forest and a little computer desk and a lovely little school neighborhood and a housing unit. It looks like everybody's happy and carefree in this space. But I think we all know and understand that the reality is all of us don't live in places that look like cartoon characters, right? Some of us live in places where there is not environmentally friendly, where our housing stock is not what it should be, where our schools are not resourced and endowed the way they should be. And more importantly, I think collectively for this conversation tonight, where the places we work are dangerous places to be. And so all of these things, as you can see, should and do influence your individual health as well as community health, which is really relevant. Now, it would be terrible in on its face that we all don't live in places that are idyllic. But the other terrible thing is that the way these issues and locations are distributed is not unequal. And this is where we get to the notion of the determinants of health, health equity, and inequities. So health inequity results from this unequal distribution of power, like our right to vote, which is being challenged as we speak. Income, goods, and all other services are not equally distributed. And I'm sure that is not a surprise for anyone on the call, but I want to make sure we emphasize that. And that power inequity influences all those critical things that we talked about before, which we consider the structural determinants and conditions of daily living. So all these things may sound like they're way beyond what we should be worried about, but in our reality, this inequity influences all of us each and every day. And the issue is that it's often, unfortunately, based on things like race, ethnicity, gender, and more importantly for us now, we're really talking this place-based health status, geographic location. These really are tightly woven into the health and well-being of our communities. And we really need to be sensitized to it, and then sensitized enough to go do something, to activate and take action. Power is not generally given, and we need to understand how power works and leverage power so that all of us collectively can be healthy. And anytime, Dr. Brown, President Brown, if you want to stop and ask a question, this doesn't need to be a straight through, because I really want to make sure that what's being presented makes sense and is relevant to you. So the drivers of health inequity, I think some people would be surprised to know just how vast they are. So this is a diagram from the work of Kaiser that talks about all the things that are influences of inequity in our health system. So there's economic stability, and you'll see I've highlighted employment because obviously for APRI, this is a critical space. But when we think about employment and how many things is linked to inside that box, income, expenses, debt, medical bills, what kind of economic support we give, these things are not equally distributed and can cause health inequity. Our neighborhood and physical environments, things like what is our housing type? What transportation is available? I don't know, for the folks from Baltimore City, you know that the bus transportation system is really not built for people who don't have resources. We can't readily get around town. I think DC probably has a much better system. There are places elsewhere, urban centers, where they do, but this is also infrastructure that's deteriorating and needs to be created. Well, imagine where this matters the most. In communities that probably can least afford to have equipment that's not kept up to date. Our parks, our playgrounds, notions of walkability, the zip code, where we live. I had a slide I used to do when I did this presentation that showed for DC, if you lived along the subway line, life expectancy increased as you move further from the center of the city. That shouldn't be. Literally over 10, 15 years difference in life expectancy just by virtue of where you live. That should not be the case, but it is our reality and we need to be aware of it. Our educational system obviously is influenced by inequity, racial inequity and discrimination of other types. literacy, language, early childhood education, what vocational training is available and valued. And then of course, as an academic in a higher ed institution, higher education is not always cheap, right? So who can access that and who can afford that and not leave with a degree that's gonna cost you more than your next two houses is an important conversation to have and a source of inequity. Then food insecurity, I'm sure we've heard the conversations around food deserts. I think we're changing that language. There are places where there's food insufficiency and
Mhm,
therefore food insecurity.
mhm.
Our access to healthy options. I think we've all seen neighborhoods where you can't find a supermarket for maybe 4 or 5 miles, but you can find a McDonald's almost on every other corner. So these other issues, community safety, social context, healthcare system, all these pieces are drivers of health and inequity because all these good services that we need are not equally distributed. And they're not equally distributed to the disbenefit, that's not a word, but I just made it up, to the disbenefit of communities of color in particular and poor communities. So this is really where this is something that does not have to be. I mean, I think that's the good news. This does not have to be.
Right,
It is what is, but we can change these things because all of them lead to differences in mortality, morbidity, life expectancy, how much we have to spend on healthcare, our overall health, just walking around every day, how you're feeling physically, mentally, and then our functional limitations. All these are driven by these health inequities, and these are all things we need to kind of know and understand.
before you leave this slide right here, Dr. Sydnor, um, as you were running through the slide and looking at everything that's in each one of these hubs that you've got laid out here, it made me think about some of the preconceived ideas from folks who are not from our community. Um, for years and years, I've heard, even within our own community, people say, well, our folks don't take care of themselves.
Mhm.
And the shame for not being healthy,
Mhm.
it was crazy. And
Yeah.
talking about our diet and how we ate as if we should be ashamed of the foods that we ate. We might have to reconsider how much of it we take in. But if cooked properly, there's nothing wrong with our food that is eaten in moderation. But then the real deal came out during the pandemic. What we had access to predetermined what it was that we were taking in.
Exactly, exactly. And
Yeah.
and the pandemic just highlighted what always has been, as you said, been the case. It's just that people had to care because
Yeah.
it's now front and center and it was impacting us globally and it's not just locally. But
That's
our communities do suffer from these inequities in ways. And again, I just want to emphasize in case there's anybody on the line who thinks I'm saying we do not have to exercise, eat healthy as best we can, take time for self-care, all those critical things that are affiliated with good health. But as usual for people of color, we have to do that and then worry about more than,
Mhm.
because the duress on us is more than the individual behavior. And there's another great example. I didn't want to make the presentation too long. An epidemiologist, Kamara Jones, has a story about the gardener's tale. And basically, she presents a picture of different plants being potted in different soil. So that nature of that soil, right, that's what feeds you. And the plant that grows out of that soil is going to grow differentially depending on how enriched the soil is. Well, the soil is society. Those are our contexts and our resources and our places where we live, work, and play. And then we're the plant. But if a plant's not enriched, doesn't have enriched soil, doesn't get sunlight, and doesn't get water, it's the same plant. It came from the same seed box, but it is not going to grow the same way. So these are all
That's right.
really, really good examples of why these inequities just aren't about our individual behavior. And as we increase our research around epigenetics and stress, it becomes really clear how the pressures of living in under-resourced communities, communities that are marginalized, not well cared for, that are physically not in good shape, they literally can get into our genes, into our mental state. So the research is coming along to kind of undergird what we've already known, but now we have ways to document it, and then we can start understanding some pathways forward as well. So I'm glad you made that emphasis. And COVID really, I wasn't going to do COVID tonight because COVID really has devastated many communities, and we don't know yet the full impact of COVID. We've got the death numbers.
Mhm.
Unfortunately, the aftermath of that in terms of education, mental health, we've seen the data from the CDC today talking about the number of overdose cases and deaths. They have
Mm.
disproportionately been in communities of color. COVID is still having its way, and we need to be aware and mindful as we continue to have these discussions. So this employment and health are inextricably linked. So in the United States of America and across most of the world, people are highly tied to their jobs. It used to be when I was a homemaker, a stay-at-home wife, the question I used to hate when we would go out with my husband, the first question somebody would ask me was, "Hi, what do you do for a living?" And to be honest, I used to get a little offended. It's like, do I have to do something to warrant being able to live? But in this country, yes, people want to know what you do and what's your job, what's your occupation, how you make your living, how are you worth my time and energy and effort. So we know for these kind of basic reasons that employment and health are really inextricably linked, both in terms of employment causing health and then health having influences on employment. And so I just wanted to make sure, particularly for APRI, given this is a labor organization, that you sit at the heart of health and well-being by the virtue of the work that you do. And I know you know this from experience, but it really does matter in every which way you can think about it. Our physical health, our ability to kind of be mobile and get around the world, our ability to create an umbrella of protection around ourselves and our family, ability to save money, ability to have a home, all these are linked to employment. And when you don't have these things, I hate to tell you, things do not go well. When all these things are not working well and in the right direction, our health status generally tends to be moving in that opposite direction. So the better the employment, the higher the income, the higher the education, the better the health outcomes. And then so the reverse is true. And again, this is research, not just hearsay. There's stuff to back this up. And let me know how I'm running on time, because once I get to chit chatting about this stuff, start talking. Anyway, this was just a piece I pulled from the WHO, World Health Organization, again, to let us all be aware this is a global issue. This isn't just a US issue or a local issue. It is a global issue. And occupational health is a major area of work done under the World Health Organization. So this is just a stat on working hours. And I actually didn't know this. I pulled it today when I went to the web, that working 55 or more hours per week increases the risk of a stroke by 35%. It's like, wow, I'm in trouble. So probably half of you on this call are probably in trouble, need to think about it. Now, does that mean you in particular? No, these are about averages. This is about a whole bunch of data aggregated over time. There's a lot of context you have to add to this, like where you work, how you work. So it's not like everybody who works over 55 hours is more likely to stroke. I want to be clear, but the big picture of it, when you look at the big aggregate of the data, that people who work extensive hours need to think about what it is they're doing and make sure that other aspects of their life are well-grounded. It increases the risk for heart disease, cardiovascular disease, and then premature death due to long working hours. And we all know, I think, that working long hours is probably highly linked to being stressed, right? If you're having to work that much, there's a lot of stress going on because it's work-life balance, and it's hard to work in a 55-hour-a-week job, whether it's a sit behind my desk job or a manual labor job. How much time do you have left to take care of yourself and your family and all those other things that are going on? So again, just to emphasize, this is a global issue, that it is particular to folks who are sort of don't have control probably over their work environment, or do and don't realize that these things actually can be detrimental to their health. And we need to understand how we work matters. So I think that really is the point of this slide for me. Did you have any comments, President Brown, or questions that you wanted to?
Yeah, actually I do. Well, are the stats different for women than they are for men?
They do, and I didn't. So they're actually full report on this website. That's why I always try to add a link. You can go to the website and pull down the full link and break down. There are always gender variations. There'll be income variation. There'll be educational variation. Because we all kind of know the stereotype of the type A corporate leader who winds up having a heart attack the day after they retire or something. So it does vary by gender, by work type, and a few other things. So there are some nuances to this that bear some further discussion. If you wanted to have a more full, like a women's health, a women in the workplace kind of discussion, we could certainly build some more information around that platform.
Oh, that sounds to me like there was an open invitation to have you back, and we will take it up. I have witnesses. We will take you up on that offer right now, specifically for that topic.
I did, Fred Mason, if you're listening, you know what?
Absolutely.
I'm always happy, and I think talking about women's health in particular, women of color in particular, in the work environment is a necessary continuing conversation. Does not mean men are any less relevant before any of the men on the call go, here they go with the women thing. No, we all have issues that we need to understand what our particular issues are and what the particular risks are, and then what we can do to mitigate them. So I'm happy to be equal opportunity and have some gentlemen come and talk about male health in the workplace to offset the women's health discussions.
Okay.
Just so we're fair.
Well, I love that.
Right. I'm health
Okay,
equity,
thank you.
so I have to be equitable. It may not be me, but we will make sure that we cover all bases so everybody's fully informed. And then this last piece, and I just remember when I started doing this work, I wanted to make sure it was relevant for APRI, not just my standard, I'm giving you my social determinants of health story.
Mhm.
I actually, for my doctoral dissertation, looked at employment. Strangely enough, as public health, my dissertation was about pathways to employment. And I followed a longitudinal study. I had secondary data from early childhood, adolescence, and adulthood to see what things predicted unemployment. So it was a crazy looking dissertation, but it got me through. But the essence of it was that these really early childhood factors influences down the line. So I want to make sure that we, as we do this work as adults, that we don't forget that the roots begin very, very early in childhood. So labor's relationship with early childhood education, I think, is critical. Making sure that family income and education, where there are children in the household or whatever, is strong and well supported by the work that you do, because this early feeder was a predictor over like a over 30-year span and whether or not somebody was employed. That should not be. I mean, I literally, the analysis, I did not expect to find it. It was just me trying to understand things, but it held up in that reality. And the places that were critical were about that family context and that early childhood education really is a driver of adult employment outcomes, as well as adult mental health and overall health outcomes. So in adolescence, we still have to worry about education. It persists, our peer networks and community. And then as adults, obviously our social network is the place where many of us get our jobs from, right? I mean, how many people have gotten a job because they knew somebody in their network who had a connection to somebody in the network? I know I did. I'm putting my hand up. My career pathway has always been driven by who's in my network, who's in my family, who knows me, who I can connect with. So you think about communities, families, individuals who don't have the networks that lead them to the outcomes that can't move you to a job that gives you more than a living wage. So think about all the folks who are in those situations and how early that begins, but independently at every stage, we need to understand all these elements that pertain. So as adults, we do need to focus on education. We do need to focus on expanding our networks, having strong and healthy networks, having strong and healthy communities, because at least the research I've done, and then I think this continues to be held up, these things really do matter. And we need to be strategic and long-term thinkers around this work. So I just wanted, I don't generally share this because I kind of hide it away, but I wanted, for you, President Brown, I brought it out and it's like, we need to talk about these things. And I think in ways, I hope that you understand that they make sense and not overly academic-y.
No, absolutely. Absolutely makes sense.
Great. And so the last, I think I'm coming toward the end, my observations, this really has been just sort of empirical observations as well as experiential, that these inequities have a strong racial and spatial component. I think that we've just had a global acknowledgement that structural racism is an international problem.
Mm-hmm.
That's on the table. That's not somebody's opinion. We've documented that, and that's now part of our international agenda. President Biden has made equity a centerpiece of his administration and his work. So these things are not just things that certain people talk about. It is now an international conversation. Equal allocation of resources where inequity exists does not resolve the problem. And what do we mean by this? Often we try to solve the problem by saying, okay, you didn't have this, so I'm gonna make sure you get it the next time around. I'm gonna give you 50 cents and give you 50 cents. But if one of us started with $100 in our pocket and the others of us started with $1 in our pocket, giving 50 cents or $50 or $500 has a differential impact. So we have to get past the language of equal is not equitable. And I know it's a hard notion to get to because we don't want to discriminate as we try to achieve inequity, but there's got to be differential allocation until we achieve equity, and then equality gets to come into the picture. But we do need to distinguish equality and equity and understand the difference between the two. And because of that, I do think the standard practices fail to address systemic issues. So we're going to improve how we do things, again, for the same reason. You may be improving how you do things, but the benefit is to all, supposedly, but there are some who've been more greatly disadvantaged. So the same systems that produced inequity can't be the same systems used to resolve inequity, right? So this is the point where we need to think about being transformative to the bottom point, that systemic change is necessary. Individual action is great. Collective action is beautiful. That collective action needs to wind up in systemic change and restructuring, doing things completely the way we have not done them before, because the system needs to be disrupted. Otherwise, inequities just keep getting recycled over and over again in a slightly different form. And some people may feel slightly better about the effort, but we're not really changing those numbers. And I didn't show the health data because I always find it to be sometimes overwhelming to just show how people of color and certain people's in income categories are always at the bottom of the health spectrum. So we know that to be the reality, but we need to start taking this forward look, and forward look means we need to be transformative in our approaches. So some of the work I hope that will help to transform or be part of that community is the newly established Morgan Center for Urban Health Equity. The state gave Morgan $3 million, and the president of the university decided that that investment would go to the School of Community Health and Policy, of which I am dean, to generate a Center for Urban Health Equity. And inside the center, we have three kind of key cornerstones of the work. One is to engage in action-oriented research and practice. No theoretical research is going to be coming out of the center. It's going to be applied, meaningful for community and for the institution. The second side is going to be driven by an asset-based model. We already know that communities and organizations and collectives have resources and assets within them, and we don't always have to approach community as if they're just needy. They have things, they have ideas, they have resources, all these pieces to the puzzle, and we need to come and bring our research agenda from that framework and standpoint. And then the last piece, which for me is like the cornerstone of the universe, is its network-driven collaboration and coordination. We have too many projects that are siloed. You do this thing, you do that thing, I do that thing. We're all doing the same thing, we all get nowhere, right? We need to end that and take on a much more collaborative, coordinated, collective frame for getting to achieving health equity, which for me at the end of the day is the kind of mission driven, my kind of North Star around this work is achieving a status where I'm in another group, one of our organizations, Morgan Cares on campus. It really is, we need to get to the point where we don't have to struggle to be well, right? It's this daily struggle. Why do we to get what everybody else has? So for me, yeah, equity is where everybody, if we're gonna struggle, then we're all equally struggling. but it can't be certain people who just have to fight every day for the most basic of things that really belong to all of us. And so the work of the center is designed to do that. We are looking for partners and community collaborators to expand our network for anybody who's invested in social justice, health equity from this standpoint. Morgan is looking to have relationships and build upon those things because again, there's no way we're doing this alone. And we're going to be working with the other HBCUs in Maryland. And then we're going to move from there because, you know, we need to practice what we preach. This collaboration versus competition is another one of kind of our sayings that we really got to do this in all our collective best interest.
That's right.
So, with that, I will just say thank you and happy to.
Oh my goodness, you are amazing. You are absolutely amazing. You took us to school, you gave us the information, we were able to absorb what you were giving us. And now comes the other part. You know where the first question came from.
Fred Mason.
There you go. But before we ask his question, I just want you to know that people have checked in from North Carolina to hear you speak, from Washington, D.C. to hear you speak, from Virginia to hear you speak. Your reputation precedes you. But that first person that popped up was Brother Fred Mason. And he says, will Dr. Sydnor elaborate on we are not a flawed people?
Fred, you're not supposed to bring private conversations into public forum. Fred Mason and I were having a conversation. We always have these conversations. Just full disclosure for the folks on the line, Fred Mason is a friend, part of our advisory board, and somebody who constantly challenges me personally to always do the right thing. And so I think we were having conversations around people of color and our health and well-being, and why we're always the problem. You know, in general, you know, communities of color are regarded as problematic people, and the position is always, what are you not doing right? You must not be doing something right, otherwise you would not be in the conditions that you're in. And so this does set up this kind of narrative or assumption of the flawed person of color. And we're not flawed people. We thrive. And when I say we, again, I'm embracing my femaleness, my, you know, my color, all of those things in this kind of collective we. Those folks who are being considered outside and at the margins, that's how I identify and kind of place myself. Always being considered problematic. And in reality, people who are oppressed and have had to struggle, we are more than. We thrive in the face of adversity, which if you're gonna, if you believe in this kind of survivor or the fittest model, my goodness, we have survived, right? We have done more than survive. And this is not claiming a space that nobody else can claim. So I don't want to get lost in people. This is not, we're better than. This is simply our experience, how we've come through our experience. Doesn't mean that other people can't. But it really is the case that almost everywhere in the world, and this is just sad, and I think Sir Walter Rodney made this quote, and if anybody wants to Google and see if I'm wrong, that everywhere the color Black is associated with poverty and things aren't good. And it's not because we're our skin color. That makes completely no sense whatsoever when you look at it from a genetic standpoint. Makes no sense whatsoever. These are kind of social, cultural constructions that put us here. But we are not a flawed people. So Fred, I hope that answered your, I mean, you got what you wanted me to say out on the table. But yeah, it is. And again, it's never we are better than, we are more than. We are who we are. And every group of folks, and however you want to, this new language of intersectionality is what has come to the table. We bring so many identities to the table, but that color identity is one of the most pervasive, persistent, problematic, I think, in world history, And so that's what I meant by that comment. Yeah.
Okay, I'm going to ask Jan if she would to pull the questions down from the chat. I see that there are now 2 there. Would you do that for us, Jan, please?
Sure. Let's see, from Wilhelmina Daniel. How are we doing in getting more of our young people in the medical field? And she's a member of the Williams family.
So that's actually a good, a good and interesting question. So there are a lot of programs around workforce development, pipeline. I want to make sure I didn't do anything wrong when I clicked out. I may have changed the screen. There are a lot of things we're doing in terms of workforce development, trying to move, excuse me, trying to move uh, people of color in particular into the medical profession. So there literally is work and funding in this area to make sure that um, we can afford it, we have interest in it. I mean, when you think about my cousin is a pediatrician and the loans he came out of school with, he is still living with them, right? He's been in practice, I don't know how long, and he is still paying off loans. So I think some of the things we're doing is encouraging early interest in STEM and some of these careers. Some of the other things, the explicit workforce development by the federal government and state around getting people of color into the health professions. Our HBCUs are trying to obviously make sure our students get a degree, can move on and go to med school. So I think there are multiple pathways opening up. But the other thing is the medical profession for young people needs to be lucrative, right? So some of the conversation has been around the cost of a medical degree versus other industries where sometimes these young people don't need advanced expensive degrees to be successful. So we need to begin to understand these models that help attract these careers for our young people so that they make a meaningful choice for a career option, that they have support and mentorship in moving through these programs. And we also need to transform the medical model. I think for some reason, the way we practice medicine may not be attracting other people because it has become more of a business and a commodity than a helping industry. So I think there are a number of factors that influence how and why people move in this space. All of these are my kind of thoughts and opinions, not necessarily coming from a medical school standpoint, but from what I've seen, this really is the issue. And you see fewer males and you see women in particular in certain kind of professions within medicine that are lower paying. So I think all these things are contributing and we just have some work to do. But I'm sure the National Medical Association is doing its part to drive more people of color into the medical profession.
Well, Dr. Sydnor, and Jan, I don't mean to jump in front of you because I know there's another question that's there. But there was something on, and I can't remember whether it was Nightline, Dateline, or one of those lines that was talking about the medical profession and the fact that when African Americans were treated by African American doctors, the care was more thorough and the outcome was really measurably different. And it was a plus plus. And they were concerned about the numbers of Black folk in the profession shrinking in huge numbers, and talking to various HBCUs to see what the root cause was for that. And you just popped up right away and started talking about the cost. And the cost was so exorbitant. It led to mental health issues, and it certainly led to debt that existed for years and years and years beyond graduation, which was deterrent for getting folks into the medical field. So I appreciate your comments about looking at other kinds of employment and looking at creative ways to get into the medical employment, because that stuff is for real. I could not believe some of the totals that they said that some of the students left with after obtaining their degrees.
And I think Dr. Copeland from the last presentation, for those who were on that webinar,
Mm-hmm.
the Bernard Tyson's School of Medicine,
Mm-hmm.
pay for tuition. Things like that will make a huge difference.
Mm-hmm.
If you can leave medical school without debt, I'd go back to school. I would be a physician if I had that kind of opportunity. I think corporate responsibility and accountability in this space will be critical. Pharmaceuticals are now making, for anybody who's affiliated with pharmaceutical companies, are making pretty good money out of COVID and the vaccines. So why not channel some of that money back into the communities where that money is, being generated in large portion, and fund some of our students to move into med school and start funding them early. I mean, we need to start cultivating our kids earlier the better. Middle school, high school for sure, to help career track them, and then to give them the opportunities when they get into med school and have to go to residencies, that they have the opportunity to get into these prime residencies where, again, they get into a different kind of network where they can
Mhm.
leverage themselves.
Well, thank you for that. And Jan, I'm stepping out of your way now. Please take the rest.
Okay, so we have a question from Israel Kesson. He wants to know about the addictive population. He says that the addictive population has extraordinary problems that we try to solve with ordinary methods, especially when it comes to COVID. What are we able to do that is extraordinary to deal with this problem?
Hi, Israel, how you doing? I'm actually on the racial disparities task force around opioids, and I know that's not the whole problem, but a big part of the problem. And what we have been actually challenged in the state for the task force to do is to think of innovative ways. One of the conversations I've had, and that's based on my actually conversations with you, Israel, is to say, stop looking at the person, this addictive person, as being the only problem. There's an entire system in which addiction evolves. And it's not just an individual who's making a decision that they want to be addicted and they're therefore all these, and therefore they have the ability to make all these changes in their communities. They really don't. There's a whole network that is, as you well know, around addiction. And we need to look at the individual and the network at the same time. And then obviously treating addiction as we have begun to do over opioids, unfortunately a little late, seeing it as a disease, a health problem, and not a criminal problem. So I think these are some of the things we're doing to make some headway. But in my mind, again, it's a structural problem. And if we don't do a both and, treat addiction, have more readily available services, have more folks who are out there who can connect with folks who have addictions, create support networks that are meaningful and readily accessible without going through a lot of hoops. At the same time, we're looking at the structures that help drive addiction and make it possible to continue it in the first place. I think these are some of the things that we need to begin to do. It's not an area where I'm an expert, but it is an area where I think that we need to have more insight and information. And then the other thing, I think public health has to be very honest around the conversation around addiction for all communities. Sometimes it's only seen as a Black people's problem, again, as if only Black communities have addictive problems. There's a reason for that, and we need to change the narrative and be honest, because every addicted person needs the help and support. And so I think actually some people are underserved who are not Black because some communities don't even want to talk about the addiction. I think the opioid epidemic has kind of blown the lid off of it. And I'm happy to have kind of more follow-up and conversation about that for anybody who has kind of insights and recommendations that I can take to the task force around this work.
Okay, and there's one more. We have our guest who will be here with us next week, I believe. Dr. Larice Edwards asked a question. She also first wants to comment that it was a great presentation, which I think we all would agree. Her question is, what's your opinion around the language of the social determinants of health? Does the term determinants leave community with no way out? What about those who are resilient and can move out of their circumstances?
Oh, wow. Okay, of course. Is this presentation over now? No. No, language is a powerful thing. I mean, it really is. And I do struggle with this notion of determinants in the way I think the question was asked. Does it leave people feeling as though that this is a fate that you can't escape? I think that's always a problem when we start talking about probabilities and numbers and these things around public health. People begin to feel like they don't have any way out, they don't have any choice. But so I get the concern. I think the reason why I probably want to continue to utilize the language of determinants and then contextualize and explain it is because it is a major influence. I guess we could say structural influences, but then that sort of takes the weight off the system. And I don't want any weight to be taken off structures and systems. They need a systematic, we need to understand that these forces are large and overwhelming, and they are different. They are fundamentally things that we have to overcome. Because you use the language of resilience. Resilient means something happened to you and you got to recover from it. Invulnerable means you've been attacked, but you weren't harmed by it. The language still suggests, and I think correctly so, that our environment has an influence on how we, critical influence on how well we do. It never takes away individualism. It never takes away what individuals can do, but I'm speaking from a public health standpoint, a population health. Individuals should, you have to decide whether or not language of determination fits for what you do individually. But I think in a public health population-based perspective, it is important that this language makes it very clear that we see it, we understand it, and that structure needs to be changed in order for our health to be improved. So, yeah.
Wow, Dr. Sydnor, you have done it again. And I'm glad you gave a commitment to come back. I've got witnesses. Because there are tons of questions that are coming on the screen, and including some that are saying she's the best dean ever with exclamation points, which is amazing.
There's a little prejudice on that one, but
Well,
yeah.
that's all right. We happen to agree with it wholeheartedly because you have done an amazing job during the course of this long relationship with the A. Philip Randolph Institute, and we appreciate you so much. Our videographer is flashing us to say that's all. You have to leave. We are about 10 minutes over, but I knew that was going to happen with you because we love what you say, because you say it with passion and compassion, and you say it so clearly. No one is left behind.
Thank you.
Dr. Kim Sydnor, thank you so very, very much.
Thank you, APRI, and everybody who was on the call. Take care.
Yes, thank you so much. And thanks to everybody who was on the call for sure.
All right. Bye-bye.
Okay. Good night now. Thanks, everybody. Okay.